So I'm going to be talking about transportation, like I said, that's the title of the presentation. Transportation is a social determinant of health in Pitt County. I'm going to take a little bit of a roundabout way to get to it, but we'll see where we're going after we get there. So, oh, there we go. No disclosures. So usual day in, there we go. So our usual day in resident clinic. So I did emergency and I did internal medicine, which meant that I had to spend a fair amount of time in my residencies doing clinic work, which means spending a lot of time sitting and then alternately running around a pretty small office trying to get stuff figured out. So most of the time, you have a varying difference of opinion on what happens when a patient doesn't show up to clinic. Usually, if you're an attending, you sort of have this kind of quiet, you're a little concerned, and if you're a resident, your response is kind of like, yes. I have a little bit of time to actually get the notes done, and I'll say a lot of times when I'm doing clinic, because I'm running around doing so much work, I don't necessarily even notice if a patient doesn't show up. Now, what will usually happen is when someone does this or someone doesn't come up to my clinic visits often enough, they'll end up with this code attached to their chart. And has anyone ever put this code on someone's chart? Do we know what this ICD-10 is? The ICD-10 code is for? It's taking a second. There you go. Non-compliant with medical treatment and or regimen, which from a resident standpoint is, again, kind of like a yes. It's a great way to just say, hey, you know what? I have no bearing on the outcome of this patient. I'm just absolving myself of all responsibility here. And so it's a little disingenuous when we talk about it in the long term too, because ultimately in medical training and medicine is supposed to be about pattern recognition, right? And so we look at patients' skin, we look at patients' labs, we look at patients' behaviors, and we think, okay, this is a pattern that's consistent with pneumonia. This is a pattern that's consistent with major depressive disorder. But yet none of us really think about the social aspects of it or the patterns that come into stuff leading to patients being, non-compliant with medical treatment. So what we have to do is then think about different ways why patients don't show up. A lot of times, I don't get the opportunity to do that. If you go to our clinic and you don't show up for 3 visits in a row without giving us a reason, you're pretty much fired. You don't get to come. And so we don't really get the opportunity to meet these patients. We don't get the opportunity to follow them through this period because all it takes is 3 strikes and then you have to go find another primary care provider, which from a clinic standpoint makes sense because we have to make sure that we're having spots open so people who can come can see us. But from a public health standpoint, it seems kind of reverse that we're not doing more to try and figure out what's stopping these patients from coming here. My project sort of started off looking initially at stuff in the emergency department because I was tired of seeing patients who were coming in via EMS with what seemed like a very, very non-emergent condition, and then kind of progressed into a whole bunch of different areas when I realized that that was going to be way too big of a project or even a thought process for me to be able to break off and get that done with. So I'm going to just be focusing on Pitt County. Pitt County is over in eastern North Carolina. It's probably about an hour and a half, 2 hours away from where we are. And you can see that there's really maybe one major city in in Pitt County. It's Greenville. And for the most part, Greenville is the major city that's east of I-95, unless we're talking about Wilmington, and that's fairly far away. The catchment area for the hospital and the catchment area for our primary care actually extends significantly farther beyond this area into a very, very rural area too. Large portions, several counties are 100% rural population. Greenville is maybe 50% rural, maybe 50% urban, and so that's part of where we have to get talking into. It's large, and when counties are large and when transportation is an issue, you get into the problem of how do you get the patient either from their home to the office so they can actually see the provider or the other way around. So in general, Greenville and Pitt County is not doing well. So about 24% of our population, about a quarter lives below the federal poverty level, 15% are just absolutely uninsured, and 27%, almost a third of our patients are reliant on either Medicare or Medicaid to take care of their costs of care. This is not counting all of the other chronic illnesses that we see in here. From a hypertension, diabetes standpoint, we're roughly at state average. That's about anywhere between 50 to 60% we're looking at. Obesity, 60%. We do have some oddly high rates of infectious diseases, including HIV and syphilis. A lot of diseases in general that are not going to just be a quick one-off, go to the urgent care, knock that out, and you'll be fine. It's just HIV. So looking around, what I was trying to do is I was trying to figure out what options do these patients actually have available to them. And so this is the bus system for Pitt County. And you're going to notice at least one thing right off, which is this is Greenville, pretty much. The public transportation system really just serves Greenville proper. There's a little bit across when you get across the river, but for the most part, even then, it's downtown Greenville and a couple relatively high-trafficked portions. But anything else outside of that, you might be able to get with the paratransit service, which you have to call, and you only get a certain time period a day, and you have to call like 3 days in advance, which again kind of gets me out of the range where I was talking about the emergency services. Then this only covers maybe 51% of our population in the area. That's 49% of several million people that are, several million, that's a little bit over, of a fairly large population of people that are just without the possibility of public transportation that can actually get them in a reasonable period of time to and from physician visits and evaluations. So there's been several studies that have looked at a couple different ways that we can do this. Medicaid, so our actual options that we have available after talking with the different physician offices, public health services, and the case managers that we have within the emergency department in the hospital are pretty much this. You've got Medicaid and transportation, which will cover at least a portion of our indigent population, but really, even then, if you qualify for Medicaid, you're still not necessarily going to get that, so that's still maybe a portion of that 20-some%. The Veterans Affairs, which will get you to and from the VA, and maybe a couple other things there, but again, fairly limited and limited to a certain subsegment of the population, as well as basically whatever people are willing to give you. Alternative options beyond that are whatever you can pay people or basically beg people to do for you or call in favors. The rest of it is kind of on your own. So what this leads to is patients becoming progressively socially isolated from both their physicians as well as the means that they can achieve care. So as you can imagine, having these medical conditions that are going to rely on patients needing to come to physician visits frequently, and them not having the actual means with which to get to these is going to lead to overall poorer outcomes for their health in general. The studies that I've seen have more focused over on the western side of the state, or western side of the country, where there's fairly large, widespread out areas. And what they've done is, at least from a medical transportation standpoint, they've found a lot of really good value to, especially in certain chronic diseases like congestive heart failure, diabetes, hypertension. Management of these improves immensely, even from a cost effectivity standpoint, if we're actually providing them with proper transportation. Now, we don't necessarily have a good way of screening out for this besides talking with patients. And unfortunately, I sort of get myself stuck into the loop of, if I can't see the patient, I can't treat them. And if they can't see me, I can't screen them for the fact that they don't have the transportation to come and see me. We're sort of in a vicious cycle on this portion here. So a lot of what the work that I did with this was really just trying to break down and figure out what exactly is the availability that we have here. Looking through, there's a handful of options and things that we can probably push a little bit farther than what we've had done so far. There's the main things that we can think of. Really, you either take the doctor to the patient or you take the patient to the doctor. We discussed a little bit about the possibility of expanding the overall transportation assistance programs that we have here. Again, we're going to need to find money for that, and that takes money and time in order to get that done. You can talk about some other things, including home visits, but again, from a fiscal standpoint, that's really hard to get a lot of people on board with too, because not only are you going to have to decrease the number of patients you're seeing within a day, you're going to have to increase the cost and overall work. You might benefit from the ability to see more things about a certain patient, but ultimately from a Medicare, Medicaid billing standpoint, you're kind of limited, and especially as we go more towards the single payment for service thing. I think that a lot of people are going to push away from that unless this is going to be patients who are privately funding this. We have, however, made out some expansions into telehealth, which I think is probably going to be one of the more interesting things and maybe the more valuable things for us. From telehealth standpoint, you really just need to take out the communication devices, and that doesn't necessarily need to be your physician that'll move people out. You can take several people and then have them all work from a central standpoint to talk. They've made some fairly good strides over the last couple years since I've been around with both telepsych and telestroke, especially in the outlying areas. But that tends to be more focused on the regional aspect as opposed to the local aspect. Right now, I think there's still a lot of limitations that we're stuck with, and as of right now, I don't have a good fix for this, aside from pointing out the areas that we do, and really trying to advocate to make sure that patients and doctors are aware of this as being a potential problem that can be affecting their care and overall their outcomes. That's a handful of citations that I have for you here.